Hello, good evening, everyone. It's an honor and pleasure to chair the session here, the Oculoplastics Session 1. Moderators would be Dr. Michael Bernstein and myself, along with Dr. Eltoki. So without further ado, let's go to the first presentation by Dr. Michael Bernstein, who is a clinical professor of ophthalmology, USC, and the Roski Eye Institute and Keck Medicine, Los Angeles. And Dr. Bernstein would be speaking to us about filler catastrophes, what you need to know. Dr. Bernstein.
Thank you for that nice introduction and the invitation to Kasimi. This has been a wonderful meeting so far, and I really appreciate being invited and observing here. So today I'm going to speak about filler catastrophes and what you need to know. I have no financial disclosures for this portion of the talk. What prompted this talk is a patient that presented to me this year. He is 5 years after Artifil filler, and he had a terrible inflammatory reaction to it. Before the injection, he is known as a male cross-dresser. Here he is after the Artifil in C. 2 years later, he developed respiratory problems and radical facial swelling. Another surgeon did 4 chin surgeries and tried to remove the filler. And here the patient is after high-dose steroids. And as you taper the steroids, you can see the dramatic inflammatory response returns. On CT scan, you see dramatic facial swelling. Pathology shows granulomatous inflammation. Artifil is a PMMA filler that's kind of delivered in the vehicle with bovine collagen, and it's the same material that's used in intraocular lenses. So as oculofacial surgeons, as we shift to more non-surgical approaches, what we're doing is we're trading weapons and trading complications, meaning that we're using different methods to enhance people's appearance, but they also have their own complications. Why do people use fillers? Because they want to reverse the aging changes of deflation, gravitational descent, bony remodeling, tissue laxity, changes in texture of the skin, and pigmentation. Both men and women want to restore high cheekbones, full cheeks, and a well-defined jawline. And fillers are a way to do that. What's interesting is the global filler market in 2020 was 13.4 billion. It's projected to grow at 8.8% per year. And it's thought that there's been a radical increase in filler use because of the Zoom boom, growing kind of interest in physical appearance, and increased disposable income. At present, Brazil ranks number 1 for surgical procedures, and the US ranks number 1 for non-surgical products like Botox and hyaluronic acids. The dermal fillers that are readily available in the United States are absorbable and non-absorbable. The patient that was shown earlier had a non-absorbable suture. Collagen has gone out of vogue by far and away. Hyaluronic acids are used the most, followed by Radiesse or calcium hydroxyapatite. Aquamid or polyacrylamide, which is semi-permanent, is not used here, but Sculptra is, and fat grafting. Silicone is currently not approved for use in the United States. Fillers are used all over the face, as you can see on the slide on the right. It's unapproved in the United States for breast and buttock enhancement, as well as implantation into bone ligaments. It's also not recommended for injection into the glabella, nose, periorbital region, forehead, and neck. Well, why is this becoming such a huge market. It's a race to the bank for the companies that release and deliver these products. Allergan by far is #1 in the field, followed by Galderma, Merz, Evolus, which makes Juvo, and then there's Belafil, Aquamid, Myoblock, and Prolenium. And more are coming on the market, and in other countries and other states, it's much less regulated. So there's dramatic filler use throughout the world. I have 4 complications I'm going to be sharing with everybody today. By far and away, the #1 feared complication is vision loss. It can happen with any filler. What you see on the slide on the left is use of radius in the glabellar region, which caused blindness, and you can see the filler causing a branch retinal artery occlusion and a central retinal artery occlusion. It can also cause dropout of the choriocapillaris. I'm having trouble advancing here.
You can go to the bottom left corner.
You
have
got
the
it.
arrow.
Thank you for that. So blindness has been reported primarily from injecting into the glabellar, nasal area, and nasolabial fold. In 2014, Park reported basically 6 areas of vessel involvement that can cause blindness. One is the ophthalmic artery. A second is the posterior ciliaries, the central retinal artery, localized posterior ciliary, branch retinal artery, and posterior ischemic optic neuropathy. In their study, 31 patients had brain MRIs done, and 39% of the 31 patients had brain infarcts from filler injections. In 2019, the review was done of all cases of blindness. There was 190 cases, and it was blindness was caused by all fillers. By far and away, the greatest area of blindness is in the glabella and the forehead. I call it the superhighway between the internal and external carotids. The facial artery becomes the angular artery, and then there's the dorsal nasal artery, which is on the nose, which can go into both the facial artery and into the ophthalmic artery. So it's very important to be aware of the vessel anatomy and where the vessel lies relative to the soft tissues. I believe that 190 cases is an underreporting in the world literature, but you just need to be incredibly careful. Complication #2 is vascular occlusion. In each of these slides, what these infarcts represent is the distribution of the vessel that's been occluded. So in the picture on the upper left, you have a dorsal nasal artery occlusion. On the bottom left, and the distribution of the facial artery is just really well illustrated by the area of infarct. And then in the top right is the labial artery, which has been affected and causing massive lip swelling. We already discussed this patient that had Artifil put into the brow and the glabella area and the cheeks, and he had a late onset hypersensitivity reaction. Complication #4 are infections, and they can happen with any product. You can get erysipelas, which is on the top left. You can get biofilms in the radius, which was put in the nasolabial fold in the bottom left. You can get atypical mycobacteria. And in the top right, you see an infection from Aquamid, which is not currently on the market in the United States. How to avoid filler complications? Don't inject. Understand the vessel anatomy. And I personally do not treat the nose and glabella. I know a lot of my colleagues do, but blindness is something I do not want to encounter in any of my injections. I inject slowly, small aliquots. It's controversial whether aspiration helps or not. There's no evidence with a small needle. And I also think there's minimal evidence with blunt cannulas. Cannulas can similarly cause blindness. and I avoid at all costs both permanent and semi-permanent fillers. It's important to have a crash cart. Everybody reports on what you need to do. There's very little evidence-based information out there. It's clear that you should stop injecting if there's reticular vessel blanching. And for blindness with hydroxyapatite fillers, I think retrobulbar injections can help, but there's only 1 or 2 case reports which show its benefit. And so again, that's a big question mark. I think there's no data on aspirin methods to reduce IOP, compresses, Viagra or Cialis, nitro-paste, oral steroids, or hyperbaric oxygen. So to be complete, I talked about 4 different types of severe complications. In the immediate phase, you can have anaphylaxis or urticaria. In the early phase after injection, we talked about blindness and biofilms, but basically small bleeds or erythema. You can get lumps and bumps, the Tyndall effect and herpetic reactivation. And in late phases, you can get scarring, granulomas, and skin defects. I appreciate your time, and I think it behooves all of us to know the anatomy and know the risks when we inject these fillers. Thanks for your attention.
Thank you, Dr. Bernstein.
Great. Our next talk or speaker is Dr. Milind Naik, who will be talking about how to manage the lateral canthus. I look forward to hearing your talk, Dr. Naik.
All right. Are my slides visible?
Yes.
Okay. Well, once again, a big thank you to the CASIMI conference organizers, particularly Farzad, for the invite. And let's move to my topic, which is when and how to manage the lateral canthus. So what we will discuss today is very quickly the clinical anatomy, which has been up till now covered so well in the previous sessions, assessment, and surgery for the canthus. In the interest of time, I'll just cover the lateral canthal resuspension. So the canthus, if we were to strip the skin as well as the orbicularis, is the framework for the eyelid anatomy, along which the eyelid anatomy is suspended. And if we were to check the exact anatomic locations, the lateral canthus is slightly higher than the medial in youth, and it's an acute angle. And you can notice in this patient's young and a relatively older picture that as we age, apart from the other obvious signs of aging, the position of the lateral canthus definitely is relatively lower. And when we look at the terms as PEC and plasty for the canthus, PEC means surgical fixation, and plasty is actually a plastic repair of. So if we were to talk about canthopexy, which is the minimally invasive component of lateral canthus, that is what we would quickly cover today. So this is a very obvious functional canthoplasty where the involutional ectropion was corrected by a lateral canthal fixation. Here she also had a lateral canthal disinsertion, which you can see bilaterally as a rounding of the lateral canthus. In some cases, rather than performing a lateral canthal surgery, such as this case where there's a mild flare temporally as well as the lower eyelid, an extreme lateral tarsorrhaphy works much better than trying to surgically operate on the canthus. Another example of a unilateral high myopia where the lower eyelid retractor release, a fat decompression, and an extreme lateral tarsorrhaphy work. So these are just alternatives to a more extensive canthopexy, where we actually cut the canthus. But having said that, the lateral canthal descent always leads to a tired look or an old look to the eye. So this lady here with bilateral asymmetric ptosis also has the lateral canthus, which is lower as compared to the medial. So what's the aim of our cosmetic canthoplasty is to place the canthus higher. It can also be used as a method to reduce the inferior scleral show. Because you stretch the canthus superiorly and laterally, it can also reduce the lower eyelid laxity. And in some specific cosmetic desires where you have an acute angle to the lateral canthus, which is also described as an almond-shaped eye. Assessment, we all are familiar with this due to our functional training in eyelid surgeries, the lateral as well as medial canthus, as well as the distraction of the lower eyelid. So you assess all these components to know what is the status of the lateral canthus. Another important point to note is the negative vector, which means the lower inferior orbital rim and the corneal plane. If they are in the same line, or if the inferior orbital rim is forwards, then that's a positive vector, whereas a negative vector always places challenge with lower eyelid surgeries because there is no good support to the lower eyelid soft tissue. We all are aware of the classic lateral tarsal strip procedure, but coming to the minimally invasive component, I'll quickly touch upon the lateral canthal resuspension here. So this can be performed either through the pre-existing blepharoplasty incision, or in cases where you could just give a superolateral stab incision along the lid crease or just in the subbrow region. So you begin with a periosteal bite superolaterally. The same needle, this is a 6-oproline I'm using, the same needle goes in the suborbicularis plane to exit along the eyelid margin, maybe through the lateralmost meibomian orifice. And then you enter the same point, take a slightly different course through the tarsus in the suborbicularis plane and come back up to pass it again through the periosteum, a little close to the previous entry point. So that way you are actually creating the same force as that of a lateral tarsal strip, which pulls it superiorly and laterally without having to really cut the lateral canthus. And then the suture is tied and your rest of the blepharoplasty incision can be addressed as usual. So here's a case with bilateral ptosis, lower eyelid laxity. You can notice the inferior scleral show with canthal laxity, where we reattached the levator, excised a little bit of upper eyelid skin, and also did a LCR. The same lady with ptosis, where the levators were reattached and the lateral canthus was fixed to the periosteum. Here's another lady with left mild ptosis, left MMCR, along with retractor release for the lower eyelids, and a lateral canthal resuspension was performed for her. So just to summarize, we looked upon the anatomy of the lateral canthus, how to assess it, and one of the many surgeries to fix it, that is lateral canthal resuspension. Thank you very much.
Thank you so much, Milan, for your presentation. And may I introduce now Dr. Farzad Pakdel to speak about brow ptosis and the customized management.
Thank you very much for a kind invitation and for your nice introduction of me. So I'm sharing my slides. So it's a great honor for me to join this wonderful meeting again. And after that instruction course, that I'm learning a lot from our exceptional speakers here. So I will talk about the customized management of brow ptosis. So I have conflict of interest, proud to be in the authors list and wrote a chapter in this wonderful textbook wrote by Mark Bernstein, Steve Dresner, David Simimi, and Helen Merritt. So thank you very much for respecting privacy of my patients and not taking any photo or video or snapshots. So when looking at the aging face, sometimes we look at the most prominent part like the buggies or actually dermatochalasis, and if not systematically review the patient, we may miss some small parts and cannot get actually a satisfactory result. And let's have a quick look on the ideal brow when we are talking about the brow and what is the preference for the patient. Actually, a beautiful brow, it means we are talking about the gender, the age, the culture, and ethnicity, and the current fashion trends. Actually, traditionally, we say that in ladies, we have arched brow, starting from the actually head and then picking at the lateral 1/3 to 2/3, and then making horizontal and very faint, actually down slanting. So an ideal brow should be symmetric in shape, symmetric in position, appropriate volume, and naturally and youthfully we have concave appearance of the brow and subbrow actually surface, and it actually the brow should be representative for the gender for most of the people. That's arched brow for ladies, and somehow straight brows for gentlemen, and it should be harmonious to the face. Sometimes we see that the brows that after actually surgical intervention, they are not harmonious for the face of the patient. So we should always remember that beauty trends play a lot for the patient's requests for us, and the surgeon should be aware what's the beauty trends nowadays, and it should be always actually a good idea to counsel the patient about the trends and the future and the actually reversibility or irreversibility of the eyebrow jobs. So let's have a quick look on the senescent changes of the brow. When we age, actually the skin laxity increases and the skin thins, and we may see deflation, loss of the fat under the brow, and it per se causes actually descent of the brow, especially in the lateral part, and descent of the forehead and the brow, especially starting from the lateral part and then extend to medial part of the brow. And in patients with the brow ptosis, we see horizontal righties because of the compensatory action of the actually frontalis muscle to elevate the brow. So whenever you see actually righties, horizontal righties in the forehead, we should consider maybe there is a concealed or masked brow ptosis in the patient, and also may see pigmentary changes. So looking at all these lists, we see that many of these actually changes cannot be reversed by simply elevating the brow. Some of them may need to volumize the brow, to resurface the skin, and some other measures, both surgical and non-surgical. So ideal brow surgery methods should be a reliable and predictable method, should be safe and with the low complication rate and no excessive extra costs. So actually looking at this menu, look at the brows, you may see different types of the brow changes, like simply descent, asymmetricities, loss of volume, and actually deflation and other things. So we cannot say that for any of these patients we go for just one technique, elevating the brow by like endoscopic forehead lifting. The surgical goals for the patients with brow ptosis include not only the elevation of the ptotic brow, but reduction of the lateral hooding in the lateral part of the orbital tissues and elevating the lateral canthus if needed, especially for those patients with the actually canthal down slanting, and reduction of the glabellar and corrugator righties at the same time, reduction of the crow's feet, and correction of the brow asymmetry. So if we choose one technique to address the changes in the brow, we should consider these goals. So I would like to touch quickly some aspects of the brows, like shape, position, and peak of the brow, that normally our brows peak at the junction of the lateral 1/3 to medial 1/3 in the lateral actually iris. So look at the brow in this young lady that asked me to do a blepharoplasty to correct the apparent unsatisfactory appearance. So when you look at the brow, you may see that we have descent of the brow in the whole part, not just medial, but the lateral part, but also some deflation and also some shape deformity. So we should choose a method to both elevate medial and lateral, volumize the brow to make sure that we could address the patient's needs actually properly. So in a patient, we should consider the gender. It's not a good idea to elevate the lateral part of the brow for a gentleman. The patient may be not happy, especially from some cultural issues, some problems with the race, and also the trend of fashion should be considered for the patients. Especially, it's very true for the young ladies nowadays that they ask us to do like a fashion thing, and after just a couple of years, they come back and may ask, "Doc, please reverse that changes to a new one." So when you're looking at the eyelids, look at the brow. For this young, for this middle-aged lady, you may see that we have descent of the right brow and also the ptosis in the right side. So it's necessary to consider that asymmetry when you look at the face with the asymmetric brows and asymmetric eyelids. Also look at the whole face for volume loss, for facial asymmetry, ask for if there was some kind of trauma or surgery or botulinum toxin injections. Sometimes brow elevation may be compensatory to a eyelid ptosis. So it's essential to address the eyelid first, not jumping to the brows. Also, a brow tracheon distance is really important, especially when you choose a method to address the brow ptosis like endoscopic, post-tracheal incisions that may increase the brow tracheon distance. You should counsel that and consider that. If the patient has a long forehead, like in this gentleman, it's not a good idea to go for that kind of deep procedure because it further elongates that distance. The patient's desirables and surgeon's abilities is really, really important when you counsel the patient. Also, the patient's concerns usually include scar formation, the downtime, going back to work, and cost of that procedure. That really matters for the patient, actually. And it's really necessary to make sure that we could address properly to patients' preferences before choosing the method. And we should be very confident that the patient has realistic view over that procedure. Also, I found that some bony changes in some patients is really important in terms of the age of the brow descent and also the method for correction, like the prominent suprabrow bone, like in this gentleman. So when you choose a method, it's really important to look at the brows and at the bony prominences over the forehead as well. The other thing is the surgeon's facilities and abilities. If you have like everything in hand, you can have a good menu in front of yours. Otherwise, you should be you should counsel the patient about the abilities and facilities. So this lady underwent with the pretracheal forehead lifting, subcutaneous brow lifting, referred to me with the serious problems. And I want to show you, although theoretically some procedures work best, but surgeon's abilities matters a lot. The sophisticated method needs lots of experience before jumping into that method. So in this gentleman with severe brow ptosis and the horizontal frown, you may simply go for a mid-forehead incision and effectively elevate the brow without going for sophisticated jobs. This young gentleman with the lateral hooting, you may just do a minimal external browpexy. There's no need to jump for endoscopic brow lifting for such gentlemen. Another lady with the stent and using some anticoagulants, it's not a good idea to go for extensive jobs like endoscopic ones. And we did a great job with the brazier actually method to elevate the lateral part of the brow. Especially it's important when you confront with the heavy brows, like in this lady with asymmetric and heavy brows, you should consider a very effective method, not just internal brow pexy. That's a weak method. Like a transcoronal endoscopic method is the most preferred one to address the actually brow descent of such patients. So endoscopic brow lifting is a versatile and very good actually procedure for managing the brow ptosis, but not suitable for all patients. Sorry. So with this lady with the eyelid laxity, asymmetric brows, a bit of the brow descent, endoscopy concomitant with the upper blepharoplasty actually is a great decision for cosmetic results. In this lady with the shape deformity, certainly endoscopic brow lifting is an excellent choice. So in conclusion, the choice of the procedure for a customized brow ptosis management include an input for your evaluation results, as we discussed about the shape, position, gender, and the goal and the trends, and also the goal of that surgery and the surgeon's preference. Thank you very much for your attention.
Thank you so much, Farzad. And it's my pleasure to introduce our last speaker from Jordan, Dr. Khalil Salim, speaking about plasma exeresis after blepharoplasty.
Thank you, Dr. Assam, for the introduction. Let me just share my slides, please. I'd really like to thank the Qasimi group for the kind invitation. My name is Khalil Salim. I'm an associate professor at Mu'ta University. I'll be very happy to share some of my humble experience in using plexar or plasma exeresis following blepharoplasty. I have no financial interest in my work. We'll start with what's plexar or plasma exeresis. This is a cordless surgical, let's say, soft surgical device that conveys high energy to a localized area of skin. Usually it's a small lightning, and it causes the skin to evaporate. So the solid will be converted into vapor through a process called sublimation. The procedure is simple. I use anesthesia around 10% xylocaine only, and I've been using plasma exeresis since 2016 when it was first introduced to Jordan. So whenever you are starting something, you just go by the book. So this is one of my first cases ever done, or I ever did. So you can see that there's no real change other than you know, the skin became a little bit more smoother. And once I started practicing more plasma exeresis, I started to notice that whenever your spots are very far away from each other, you won't really get the desired, let's say, outcome that the patient wants and you want for the patient. This is another case that I first did. You can see that the wrinkles or the rides has decreased a lot after the session. However, the patient didn't have the outcome that she was looking for, like, for example, getting rid of this the skin. This is another case also that I did far back, 2017. You can see that the lower lid rights has disappeared after plexar, but still there's a skin fold. And that's because it was more or less superficial, and as I've said, the spots were a little bit far away from each other. Plexer, also I've used Plexer to get rid of, let's say, dark circles. However, it's a big no for me now, especially in our race. Plexer can induce a lot of pigmentation post-op, which I had really time treating. Some patients, it took me between 8 months to 1 year for the spots to resolve. So once I started actually using Plexer more deeper, and the spots were more or less adherent to each other, I started to get better results. This is a patient with a primary soft surgical blepharoplasty. You can see the this is the pre and this is the post-operative picture. This is another case where you can see that the skin fold has disappeared after using the same method. This is a third patient. You can notice the skin fold here. So this is her before, this is after the operation, and this is her after 2 weeks. But you can see the patient had some pigmentations. These actually disappeared after 3 months. This is another patient whom she had excess upper eyelid skin. She wasn't really very happy or keen to go to operation. And I did for her plasmapheresis, as you can see here. This is the, let me show you the picture. This is the skin, excess skin that she had. And this is the laser, let's say, spots being laid down. And this is another picture showing the preoperative and postoperative plasmapheresis. This is another case where you have where plasmapheresis was done for the lower lid. So I started to work on post-operative blepharoplasty cases, and I found that it's a great device to remove extra skin, unwanted skin fold that develops after suturing, any skin tags that can't be removed by surgery, and it can smoothen up the skin piece, especially if you have a mild brow ptosis. So let me show you some pictures. This is a patient I did for her upper lid blepharoplasty. Still, she has wasn't really very happy about the uneven arc of the upper lid. So I did for her Plexer, and this is her look after getting rid of the upper, smoothing up the upper lid crease. Another picture of the same lady. This is her preoperative, this is post-op. She wasn't happy about this small skin tag over here. And this is her after doing 1 session of Plexer. This is another patient who was referred to me by a respectable colleague. So the patient was very unhappy. She had this small skin tag over here, and this is skin, excess skin over there as well. And this is her after having the operation directly, immediately. And this is the other eye. You can see the excess skin tag here, which was removed by plasmapheresis. And she turned happy. Another case where I combined both, surgical with the soft surgery or plasmapheresis. This lady had an upper lid blepharoplasty with 1 session plasmapheresis. You can notice that the rights or the wrinkles has disappeared, along with the but she had few skin wrinkles that I had to do another session for her. and she developed some small pigmentation that disappeared afterwards. I've noticed that young patients, dark colored, those with freckles on the hands or the face due to sunburn or sun injury, were more likely to develop freckles rather than the other people. So this is another lady. She wanted to have rapid recovery because she's an employee. So I did for her upper lid blepharoplasty and lower lid plasmapheresis. And this is her picture immediately after the, let's say, the operation. And this is her picture after 5 days. So you can notice that most of the burns have, disappeared, and she can go back to work very rapidly. And this is her after 6 months. This is another lady. I did for her upper lid blepharoplasty with lower lid plasmapheresis, and this is her post-operative picture. She wasn't happy about the lower lid pigmentation that we had really tough time treating. Another lady with multiple suture bumps and lumps that was referred to me by a respectable colleague. So I actually removed them using plasmapheresis as well, and the patient had a smoother surface. Plasmapheresis, I've tried actually using plasmapheresis on xanthelasmas, and there is recent quite literature on it. So you can see this is the before, this is the after picture, and this is the patient after 2 months. So why plasmapheresis? Well, for example, if you have a case like this one, you will hate actually going to surgery. You will hate really operating on such a patient. But with plasmapheresis, the nice thing is that you try your best to remove as much as you can, and the sessions are repeatable. This is here after one session. As I got more experience with those cases, I found that you really need to go deep, and you have to go up to the orbicularis muscle. You have to remove all the yellowish area because recurrence is high, and things, or let's say these lesions recur not because you have missed some of them, or let's say missed part of them, but rather the patient has this propensity, they have the thing to develop those lesions. And this is here after 3 sessions, actually, 1 year after, 1 year later. And Plexer can also remove warts that you really don't want to remove them during surgery. This is the before and after picture. Multiple walls also easily removed by Plexer as well. And even you can remove tracheoepithelioma, the tribal marks. So you can see this is the before, this is the after picture. And I did another session to remove this area here as well. This is a dental lady also. She had multiple tracheoepithelioma all over her face. And we've removed the smaller ones over here. And then she was a little bit more encouraged to remove the larger ones. And thank you so much for your time. Thank you. Any questions?
Thank you very much. Great presentation. So may I ask questions? Mike, Milan, can I ask a question?
Yeah, go ahead.
Thank you, Dr. Al-Salem. Great presentation. Actually, it's a new topic in oculoplastic. So it was really interesting to see your results. So to me, Plexer is addressing just the ocular surface, not the other senescent changes like fat prolapse or brow ptosis or other things. So I would like to know the indications for plexer blepharoplasty. What's your indications? How do you choose your patients?
Well, first of all, if we are dealing only with dermatochalasis, then plexer might do the job. However, if you have brow ptosis with it, you have a fat prolapse, ptosis, for example, all these won't be addressed by plexer. So I would really urge the patient to go to surgery. But I found that to get a more effective, let's say, post-plexer result, it's important to be deep. You have to go beyond the dermis, because you won't be able to induce a structural change. Otherwise, you're just burning the skin. So you have to be deep. The lines should be, your spots should be very near to each other, so that as if you are brushing the area. That's that's much better than just doing those spots all over, and you won't really get a good result. The patient won't be happy.
Actually, your results were fantastic. So I would like to make a comment if I'm allowed. So I've seen patients that has actually done plexer, referred to me after the plexer for eyelid retraction. And so I checked these patients and found that many of those with the periorbital plexer, all of them had lower lid laxity. So to me, if the patient has lower lid laxity, I think it's not a good idea to go for the plexer before the correction of that laxity. So I'm not sure what's the idea of the other colleagues, Milan, Mike, and Dr. Essam El-Touki about the plexer.
I don't have much experience actually with it.
Same with me, Farzad. No experience with plexer, but it was a.
Dr. Mike, you'll really love the device once you buy it. It really saves you, because you really get all of those patients. They're very unhappy about I have a little bit here, a little bit there. You don't want to get them back to surgery, so you can just let's say redraw the eyelid with plexer, and it really helped me to get better reputations among my patients and doctors.
Mike, you are muted.
You are muted.
How do they respond to the hyperpigmentation and the length of time to recover? It seems like in patients that have a Fitzpatrick type 3 that are Asian or Middle Eastern, it would be really problematic.
Well, I totally agree. You have to prepare your patient for the surprise. You have to tell them that pigmentation is really highly, it might occur, and especially those who can develop freckles after exposure to sun, or if they were young, if they were heavily pigmented, for example, African dark, that dark. But mostly it's not that bad. Most of them, they will recover within 3 months, I guess. And pigmentation, I say it's only 10-15% of the whole whole of my cases that I did. I did over 1,500 cases of plexer between surgeries and primarily, doing the thing. So, or let's say soft surgery. So yes, I, had this problem. However, you just give them, for example, ointments like Optim Eyes, eye revitalizer, something that will just, or dark spot eraser, something that will get rid of the dark spots.
Thank you. So we have just 2 minutes from now. I would like to ask question from Mikey from Alod by Mike and Milan and Dr. Essam. May I ask question?
Sure.
I just need to discuss with Milan that
Yes.
probably in the last few years, I've been almost in all my cases, I've been suspending the lateral canthal tendon, not with the tarsal strip, but with any type of suture. Because I feel that I lose nothing by doing it, but I might lose a lot if I don't, and the patient gets a lower tendon. How many of your cases do you do suspend, or is it I'm overcautious, or?
No, I think you're right. If you add that as a step in each patient, I'm sure they're going to benefit. I particularly use them in cases where I have assessed the lateral canthus to be requiring that tightening, especially in the form of inferior scleral show, or where the eyelid is not really well opposed to the eyeball, sometimes purely functional, just to oppose the punctum.
Mike,
Any
in
of the
terms
panelists?
sorry. So
Go ahead.
I would like to ask Mike in just a few seconds, because we are in just the last few seconds, to ask if you see some patients develop some vascular problem after gel injection. Can you give us a simple algorithm what to do, and where to inject, how to inject?
Right. I would have Hylenex or any kind of hyaluronidase product available and just inject a lot of it and inject it quickly. There's a very narrow window to reverse the changes. And so the more aggressive you can be, the better. We have a ton of hyaluronidase in each one of our offices for that particular reason.
So do you inject at the site of injection, or do you inject in the retrobulbar space, Mike?
If there's vision loss, the retrobulbar space, I've only had to do that once, and thankfully not with my patient, and there was no vision recovery. But you do everything you possibly can when it comes to vision loss. Anybody else have experience with it?
Milan?
Dr. Bernstein, I have a question regarding retrobulbar injection of hyaluronidase. Have you ever, injected retrobulbar? I've read some of those, case reports, but I don't know how, if you ever done it or how is it done.
Well, I grew up when I was early on in training, doing cataract surgery with retrobulbar injection, so I'm more comfortable with it now. When you learn cataract surgery, you don't have that experience, but you just go to the lateral third of the orbit, and then you aim back towards the nerve, and you do the best you can. It's unclear to me whether that helps or not.
Thank you. So I think we are just done. Dr. Al-Amri sent a message that we are done, and I would like to thank you very much from the actually great moderators, great talks, and all of the actually friends be here. So
Thank you so much.
Give the
much.
actually drive to Mike and Milan and Dr. Essam to actually conclude the session.
Thank you all so much. It's always a pleasure.
I agree.
Bye-bye.
And if you're ever in LA, we'd love to see you. So please stop by.
Thank you.
Have a great day. Stay safe, everybody.
Thank you very much. Thank you, everybody.
Thank you.
Have a great day and see you tomorrow.
Hopefully.
Bye-bye.
Bye-bye.
Bye-bye.